everyone, and welcome. My name is Dina, and I'm a member of the European Huntington Association. Usually it's Astrid who sits in this seat for the webinars, but I'm taking her place for tonight. She's on her magical trip of Peru, and actually I think she's in Machu Picchu today, if I'm not mistaken. So my co-host is Tina Leggett, so let's not, it's a little bit confusing with names, but hopefully we'll keep everything in check. And behind the scenes are Claudia and Filippo, who are going to be managing questions and other things and letting people in as we. So we are here this evening to hear about the Novartis Vibrant HD trial, which was the oral delivery of the branaplam drug. And we're joined by some of the Novartis team and a special guest. And they will be giving us an overview of the trial and trying to explain to us the reasons why this trial was halted. So that's all for me for now. I will be back. And I'm handing it over to Tina for now.
Hi, everyone. Nice to see you. For those that I can see, it's my pleasure to introduce the speakers this evening. So to fire away to the speakers, first of all, I think everybody knows Professor Bernhart Landwehrmeyer. He's a neurologist, neuroscientist, and neurology professor at the University of Ulm in Germany. And he is one of the principal investigators for the Vibrant HD trial, and also he was on the steering committee. Then from Novartis, I'd like to introduce Dr. Harry Ramos, who is medical lead for the branaplam program, and Dr. Beth Borowsky, who is the clinical lead for the branaplam program.
Today, what we'd like to do is give you an overview of both the Vibrant HD study that we had ongoing and our decision process that went into first pausing and then stopping the study. Perfect. So these are just our disclaimers. So Harry and I are both employees of Novartis, and you can see that Bernhart has a series of commitments for consulting, research, and work on clinical trials. So if we go to the next slide, perfect. So I'd like to start by giving sort of a big picture view of the history of branaplam. So branaplam was first discovered by research scientists at Novartis as an oral drug for treating a rare fatal disease called spinal muscular atrophy, or SMA for short. So we started a clinical trial in infants with SMA in 2015. And then 2 years later, we learned from a dog safety study that branaplam had the potential to cause neurotoxicity. So at that point, we carefully reviewed the data that we had already, didn't see any evidence of neurotoxicity. We modified the study protocol to add in additional assessments that could detect neurotoxicity. And then it was after that that we eventually discovered that branaplam could also lower Huntington levels in Huntington's disease animal models. And then we discovered that it actually also lowered Huntington levels in the patients, the children that were in our SMA study who'd been receiving branaplam. So this was very exciting to us. And we discussed these findings as well as the potential safety risks of branaplam with a panel of our Huntington's disease expert advisors, including Bernhart. And then in late 2021, we began a clinical trial called Vibrant HD. And this was a phase 2B trial in people with early stage Huntington's disease. And as you'll hear more about today, the study was designed to detect the earliest signals and signs of neurotoxicity. And in fact, in August of last year, we paused dosing in the study due to safety concerns. And then in December, we announced that we were terminating the development of branaplam in Huntington's disease completely. And I will say we never did see clear evidence of neurotoxicity in the SMA study. And that study completed at the end of last year after more than 7 years of treatment in some children. So, now that you've seen the history of branaplam, let's talk about where we are now and what our future plans are. So the ongoing study in Huntington's disease, Vibrant HD, is still ongoing as we continue to monitor the study participants off treatment. So participants have already been told whether they were on the placebo arm or the branaplam arm. If they were on placebo, they have now completed their participation. And if they were on branaplam, they'll have a total of 2 to 3 visits over about 1 year to monitor for resolution of signs and symptoms that they may have developed. So today I'd like to, with my colleagues, provide an overview of the observed safety findings and the decision to terminate development. Now, we recognize the importance of sharing data with the community, so we're planning what's called an interim analysis in the next few weeks, and that will allow us to present the preliminary data that we've generated at the next Huntington's conference, which is actually the CHDI conference in April. And then we'll also have the final data after the study completes at the end of the year. So the next slide, please. So as I mentioned, what led us to explore branaplam in people with Huntington's disease was the observation that branaplam lowers Huntington levels. And Huntington lowering therapies are still among the most promising approaches in development for slowing the progression of the disease. So it's well established that mutant Huntington is the main cause of disease onset and progression, and that lowering mutant Huntington in animal models provides support for slowing the progression of the disease and improving symptoms. You can see that what distinguished branaplam from the other Huntington lowering drugs that had already been tested in people with Huntington's disease was that it could be given orally. So the other Huntington lowering agents being tested were either given as repeated intrathecal injections or one-time injection directly into the brain. So branaplam was the first oral Huntington lowering drug to be tested in people with Huntington's disease. So why did we decide to start a clinical trial of branaplam in people with Huntington's? Well, first, as I said, we had demonstrated that orally administered branaplam was able to get to key regions in the brain and then lower mutant Huntington in the brain in mice. Second, before we started the study in Huntington's disease, branaplam had been studied in babies and young children with SMA for more than 6 years, and it appeared well tolerated and effective. We also knew that branaplam lowered levels of Huntington mRNA in these children. But before going into adults with Huntington's disease, we did a phase 1 study in healthy adults. And what we found in that study was that Huntington levels were lowered after a single dose of branaplam, and the findings supported weekly oral dosing in adults. And finally, we had already done a lot of safety studies in different animal models, which allowed us to identify the potential safety risks to look for in people. And before we started a clinical trial in HD, we first discussed all of these findings with an external group of Huntington's disease experts, as well as experts in specific safety topics. And together we came up with a protocol that would allow us to evaluate the ability of branaplam to lower mutant Huntington in HD patients, while also being on the lookout for the earliest signs and symptoms of any potential safety risks. So 2 of the key groups of people that we assembled to guide us through this are our data monitoring committee and our steering committee. And I'm going to pause here now and turn it over to Bernhard, who is a member of our steering committee, so that he can explain the roles and importance of both of these committees.
All right. Thanks, Beth. So the steering committee serves as an advice board. And the idea is that the steering committee, which is composed of disease experts, investigators, representatives of investigators, and very importantly, representatives of people participating in this study, potentially participating patient representatives. The idea is that all the insights that the group of experts, disease experts, and investigators and patient representatives have are brought together to inform the study design and the best way to conduct the study to yield conclusive results. What is important is that this group, the steering committee, who is all about the scientific integrity of the clinical trial conducted, it has no access to study data in an unblinded fashion. That is, none of the members of the steering committee is aware who of the participants is assigned to which group. That role, and that's an important one, of having access to the data in a way that you can tell apart who is receiving in a placebo-controlled study placebo and who the active drug is assigned to the data monitoring committee. These are independent experts. They have domain knowledge, that is, they know about Huntington's disease and they know about drug safety. And they have access to all data in such a way that you can tell apart which group is receiving active drug and which group is receiving placebo. So they are in the position to tell apart risks associated with treatment assignments and weigh the risks, balance the risk with the potential benefits that they may receive. In the case of the Vibrant HD trial, the data monitoring committee was composed of 5 members, and specifically one specialist on one aspect of the anticipated potential side effects, that is, an expert on neuropathy. What neuropathy is, we will explain a little bit later in more detail for you.
Great, thanks, Bernhard. So together with these advisors, we developed a protocol that was designed to detect and minimize the potential safety findings, which included neurotoxicity. So I mentioned earlier that we learned from some of the animal studies that branaplam might cause damage to peripheral nerves. And even though we had no evidence of such findings in our SMA trials, we designed our first trial on Huntington's disease patients in a way that allowed us to detect and then minimize this in case it occurred. So one of the things that we did was we employed what's called a staggered dosing approach. And this allowed us to look at lower doses and ensure that they were safe before moving to higher doses. And I'll show that in a minute. We also included several key safety assessments that were specifically to monitor for the earliest signs of neurotoxicity. And Harry will walk you through that shortly. And then finally, as Bernhard alluded to, we engaged with actually 2 neuropathy specialists, one on our data monitoring committee and one just as a separate advisor for discussions on both the design of the study and then the review of the data. So on the next slide, I'll just walk you through the study design and then I'll hand it over to Harry. So this is the design of the Vibrant HD study. It's a phase 2b study in people with early manifest Huntington's disease. So the goal of the study was to identify a safe and well-tolerated dose of branaplam that lowers mutant Huntington in spinal fluid sufficiently to expect a clinical benefit. So the study was intended to evaluate 3 dose cohorts in a staggered fashion. And each of these cohorts had 20 people on branaplam and then 5 on placebo. So we started with our 56 milligram dose once weekly. And this is a dose that leads to similar exposure of the drug in the brain and blood as we had in our SMA study. So the plan was to review the data from this first cohort and then open the second cohort and start dosing with 112 milligrams weekly. As you can see, and as you'll hear about, unfortunately, we had to pause dosing during this first cohort due to safety concerns. And then eventually we stopped development before we ever moved to that second dose. So I'll turn it over to Harry now to walk you through that.
Great, thank you, Beth. And we can go to the next slide. So we heard a little bit about peripheral neuropathy, and I'm going to review this a little bit, just a very, very overview, and Dr. Bernhart will provide his insights as well. So peripheral neuropathy affects the peripheral nerves. And you can see on the left diagram, there are nerves that are in blue that are outside the brain and the spinal cord. These are the nerves that are affected. And what the condition can cause is numbness, tingling, weakness, and sometimes pain in the feet, legs, and hands and arms. One of the characteristics and patterns of this is that we see a length dependency with this condition, where you have an effect on the longest nerves. So those on the feet that you can see on the diagram on the right, where there's more impact first, and then this slowly progresses upward. And this is important because when we talk about how we were monitoring, it's something that I will mention as well. Causes can be from injury to the peripheral nerves, and many of these that are more common that you may or may not have heard of are related to diabetes, people with excessive alcohol use, and certain vitamins and medications can actually cause this. It can range from very mild symptoms to more severe symptoms. And it can have a greater impact on those patients that already have some type of neurological impairment that's already affecting their peripheral nervous system. That is something with gait, perhaps. This could be something that's more impacted. It can resolve on its own over time, but sometimes it may remain permanent. I don't know, Bernhart, if you wanted to add anything further from your perspective.
Well, I think you alluded to the fact that neuropathy comes in different flavors. And if you could go back one slide, on the right, you see in dark red the feet and the hands. That's reflecting what we expect in a particular type of damage to the peripheral nerves. That is the longest extension of the nerve, the so-called axon, and extending from your back at the level of your spinal cord down to the toes are the ones, as you heard already, in a length-dependent fashion are affected first. And it's often the case that you see as signs of an impairment of these long extensions of the nerve cells, the axons, that there is a change in feeling, that is numbness or tingling, and later it may translate by affecting also those nerve processes that are connected to muscles, also the strength that you can develop by innervating and muscles in various parts of the body. If you could go back to the next slide. Here is how you examine that clinically, neurologically. First of all, like in all neurological examinations, you ask about complaints, and then you test. And for instance, on the left-hand side, you see a tuning fork, and you see that the tuning fork is positioned over the big toe, actually the joint, the last joint in your toes is commonly used, and you test whether the vibrating tuning fork that the vibrations can be felt. And likewise, you test temperature, you test pain, you test with a reflex hammer, deep tendon reflexes, and you examine for each joint and both sides separately muscle strength. Harry, would you like to go on?
Yes, and I'll go on. Thank you.
Mhm.
So that was one part of our assessments, and we worked, as we mentioned before, with the steering committee to have this be a very robust plan, with the idea really to detect this at very, very early stages, so that we can be aware of it. We also incorporated nerve conduction studies. These were studies where we could test the electrical impulse through the nerves. We did this, as we were talking, in the longest nerves on the lower limbs, on the leg nerves, to detect any changes in the speed and the strength of that nerve impulse. So you can have a change that could be just in the speed or also the strength, the amount of axons that are there. So this was another way that we incorporated so that we could test these nerve cells. And we actually had baseline tests done so that we had a comparison for later. Because as we discovered, there were changes during the study, but not necessarily that they were out of range, but there were changes that were significant from their initial baseline findings. So this was really important and very different in any other HD type of study. It's not the norm to have something like this. I wasn't sure, Bernhard, looked like you wanted to.
No, I just
something.
would like to point out that these nerve conduction studies were employed because they are particularly sensitive measure. So they may precede you having any complaints or physicians during their examination picking up any abnormality. So you look, if you like, from neurological examination to nerve conduction studies to an increase in sensitivity to detect even minor alterations.
Thanks. And the next, oh, no, there was one more bullet. So the other thing that was actually quite novel here was we used blood tests for the neurofilament light chain, the NFL, which many of you have heard, I'm sure, and this is a protein that can indicate injury or damage to nerve cells. And we were using this on a very frequent basis every month, where we were measuring to check for any type of damage. Also something I think a little bit more novel in this situation where we were using this more for safety.
So if I may add, and this particular protein, the neurofilament light chain, and it is enriched in the long processes, the axons, that we suspect could potentially be damaged in the process. So you can think about this as a component of the railway system that allows impulses to travel down these very long processes. And if they can be found in blood or CSF, they are indicative of or suggestive of damage to the transport system in these long nerve processes that we call axons.
So we heard everything that was set up to check for these types of findings. So what happened? Well, we saw some initial potential peripheral neuropathy findings in 2 patients early on, and we alerted our DMC. They were aware of this and wanted us to kind of keep them up to date with what was happening. And we continued doing that on a weekly and almost every 2 weeks. We were updating them very frequently. So one of the things, at least from my perspective, being the medical lead here, was I was really keeping up on all the findings that we were seeing and keeping the DMC up to date on what we were finding. Then on their meeting that they had on the 28th of July, they had made the recommendation to temporarily suspend the study drug. The determination to stop was not made, as there was a potential to restart the study drug depending on what we would see while we pause these patients, looking for reversibility of the peripheral neuropathy, and also the potential benefit in lowering mutant Huntington as well. This was something we discussed with our steering committee, and they agreed with the recommendation, as they noted there was little tolerance for peripheral neuropathy in HD patients per se. So the concerns that were related to this potential neurotoxicity at the time of the DMC recommendation were the following. We had about a third of the participants had noted a change in their reflexes. We stated earlier that this was one of the findings that we wanted to check for early findings in peripheral neuropathy. So changes in reflexes could be there's a decrease or absence in a reflex. About half of the patients had noted an increase in their NFL, indicating potential damage to the nervous system. We had 3 patients who had experiencing these changes with the nerve conductions as well. And 2 of patients had some numbness and abnormal feeling in their legs. One of them left the study because of it. However, both of them cleared up. Both of the symptoms cleared up in the patients. Next slide. So what were the actions following this pause? All participants stopped taking study treatment immediately, but they continued their visits, which was important because we can continue getting data on how they were doing, particularly those that were experiencing symptoms. There was a sub-team at Novartis that was unblinded so that they could see what patients were on, whether they were on active or on placebo, to determine the potential benefit over the known risks. And as they explored potential lower doses of branaplam. So the potential benefits being lowering of mutant Huntington in the CSF and weighing that against the risk of the peripheral neuropathy that we were seeing. So this sub-team made the recommendation to discontinue the development of branaplam. And this was endorsed by the DMC, our steering committee, and several Novartis internal boards as well, and communicated in December of last year. So the key findings that led to this decision were the following. Many had symptoms consistent for neuropathy, whether these were reports of symptoms, findings on their neurological exam, and also nerve conduction. These increases, as we mentioned before, for the NFL, and something new that we had not seen were some changes in the MRI. What we saw here was an increase in the lateral ventricle, one of the fluid spaces in the brain, something that we are continuing to review. This is very preliminary right now, and there had not been any kind of clinical symptoms attributed to these particular findings that we saw as well. And then I'll turn it over to Beth to close with our benefit risk.
Thanks, Harry. Yeah, so one of the important principles of drug development is this concept of needing to balance benefit and risk. So in this case, to assess the potential benefit of branaplam, we measured how much of this first dose, this 56 milligram dose of branaplam, lowered mutant Huntington protein. And we found that branaplam did lower mutant Huntington protein levels in spinal fluid. And this is an important first demonstration that an oral Huntington lowering agent was able to decrease mutant Huntington levels in spinal fluid, and presumably therefore also in the brain, which is where it comes from. But it's unlikely that lower doses or less frequent dosing of branaplam would lower mutant Huntingtin sufficiently to slow disease progression. And this was determined based on the modeling data, and that the level of Huntingtin lowering we saw at the current dose was right at the lower limit that you would expect for clinical benefit. Thus, the benefit risk analysis led us to recommend stopping development of branaplam in Huntington's disease. And this decision was both difficult and easy. It was easy because the balance of benefit risk was very clear. But it was difficult because we all wanted branaplam to succeed and become available as a convenient, effective treatment for people with Huntington's disease. Before we made this final decision, as Harry mentioned, we discussed the findings with both our steering committee and our data monitoring committee, and both committees were in full agreement. And since we have Bernhart here with us today, and he was part of this decision process, I'll pause and ask if he has anything to add from his perspective as both a steering committee member and a site PI as well on the decision to terminate development.
Sure. This was a disappointment and a pity, because we were all very attracted by the idea of having a pill, even only to be taken once a week, to achieve and helping to reduce the burden of mutant Huntingtin gene products, and thus they might, that was our hope, and it continues to be our hope, be associated with a change in the rate of progression of Huntington's disease. And obviously the people who participated in the trial were, when we broke the news to them that the administration of the drug was stopped, were disappointed. But they also understood that, the ones we talked to, that we had the opportunity to talk to at our sites, they understood the reasoning behind it. One of the participants at our site did experience changes that were only picked up in the markers, that is, in the nerve conduction studies, and in the NFL levels. And this person was pleased to learn that in subsequent examinations and the follow-up examinations, these changes appear to go back to normal. And though disappointed, and understood the reasoning and the decision. For us as clinicians, we felt that exchanging or the trade-off between you having a damage to your peripheral nerves, which would impair your ability to feel and impair your ability to move through weakness, and it would not outweigh the benefit that HTT lowering on the long run might bring. So it was difficult in the sense that this was yet another disappointment, but at the same time, my impression was that all the participants in the study we had at our sites appreciated the effort that went into detecting potential damage early and to react early on before actual clinical impairments were becoming apparent, alerted to the risk of damage and drawing the necessary consequences from this insight.
Just want to thank you all for listening today. As we said earlier, this isn't the branaplam story that we hope to be telling you, but we think it's important to share it with you. Obviously, a big thanks to everyone who participated in the Vibrant HD study and to the many organizations shown here who guided, encouraged, and continue to help us through this journey. So we'll stop here and see if there's any questions for us.
So thank you to our speakers. I actually have a whole bunch of questions in my head to ask, but I will ask two, and then I'll hand it over to other people because I don't want to be hogging everything. So I'll ask the two questions in succession, and then I'll let the panel decide who's going to answer. So the first one is, you did this study in healthy volunteers to begin with. Did you not see any peripheral neuropathy in those healthy volunteers? So that's my first question. And then the second one is, you stated that the SMA trial, you did intrathecal or spinal injections of the drug, but then when you decided to do the HD, it was oral. What was the decision behind that? Is there any possibility that if it was done via the spine, that you wouldn't be looking at these sort of the results? So that's me for now.
So for the first question, so in our healthy volunteer study, it was just a single dose. And we didn't see any changes. And we did look at NFL, we looked at some other markers, but even in, as Harry explained in HD patients, the earliest signs we saw were NFL. That was after 9 weeks. So, it's not unsurprising that we didn't see anything after a single dose in healthy volunteers. So the study in SMA children, that is given orally. So I think the figure I showed where there was the intrathecal injections, those I was comparing their other Huntington lowering treatments. So for example, the antisense oligos from Roche and Wave are given as intrathecal injections. But for branaplam has always been an oral, it's actually a liquid. The reason it was liquid in our study was because it was designed for children. And so there was sort of this liquid vanilla-y tasting drink that the children would have. And that's exactly what we did in HD patients. And we don't, giving it in any other route, we don't think would overcome the balance of benefit risk. So I don't know if either Harry or Bernhard want to add in on that.
Yeah, maybe if I may, I add one more thing. So I believe that the observations in healthy volunteers, and in particular, the observations in the SMA kids who have damage to nerves as well, and they suggested that this compound, branaplam, may be well tolerated, despite the observations in animals, namely dogs, and that it has the potential to interfere with a good normal function of the long processes of the nerve cells, the axons. So, and what we learn is that in Huntington's disease, it's different. Huntington's disease patients appear to respond in a different way to branaplam. And there might be a reason for this, because there's other evidence from prior studies that the long terminals of nerve cells may be altered in Huntington's disease. And I believe that's one of the important messages, that a compound that may be well tolerated in condition A may cause problems in condition B, here Huntington's disease.
Okay, thank you. That's yes. Yes, the last couple of years have been quite disappointed in some of the trials that have stopped or have changed. And I think the message also we have to give to the public is that it's a huge, huge disappointment, but there's so much that can, in the end, be learned from every single study, even if it's stopped. And so we just need to go forward and find answers, and hopefully one day something will come. So
yeah, and Tina, if I can add to that, I think we usually get this as a question, and since we didn't, I'll give the answer I would have given if I had given it. So we often get asked, do we think that this the same findings will occur with other similar, Huntington lowering agents or other Huntington splice modulators. And the one thing we don't know exactly what the mechanism is by which branaplam causes this type of peripheral neurotoxicity, but we think it is not because of Huntington lowering. And the reason for that is that the preclinical animal studies I talked about, the dog study, for example, where we saw that branaplam caused some damage to peripheral nerves, branaplam does not lower Huntington levels in those species, right? It's very selective for human Huntington lowering. So whatever its branaplam is doing in the dog to cause this peripheral neuropathy, it is not Huntington lowering. So it's probably what is called an off-target effect. Now, whether that off-target effect is shared with other compounds is possible, but it shouldn't necessarily be presumed that other Huntington lowering agents will have the same effect. So I think that that's good news for the community.
So, Dina, if I may, you pointed out, and you're quite right, that the last 2 years were difficult for the HD community. Big disappointment. But I believe it's very important to keep in mind that the main reason why it is necessary to do clinical trials is that prior to us doing them, we don't know everything. We don't know enough to predict everything. There is no substitute for trying. And that's still hard to deal with, that hopes are not meeting what we like to see. But it's part of reality that there is no substitute for us trying. And if we would know that something is working for sure, we would be in a difficult position to run placebo-controlled trials. But the reality is we don't know, short of trying.
Yes, we're in uncharted waters with all this Huntington lowering, and it is trial and error. And hopefully you can go back, and once you have all the results, and look at maybe what was the reason for the clinical or the peripheral neuropathy, and back to the drawing board, and maybe something may come out of this in future years.
Tina has a question.
Yeah, I have a question. I don't chat. I've got my hand up. So thank you for the 3 nice presentations. My question is more about what Novartis's plans are now. I know that some of you, Beth, for instance, you've been in this business for a long, long time, supporting research for Huntington's disease. So now that this is finished, do you still have a Huntington's program within Novartis?
So first to clear, so this isn't finished yet. I mean, we are going to be, this study will stay active for the rest of this year, or probably by October we'll finish, and then we'll review the data. And there's quite a bit of work. So we're committed to seeing this study through to the end. And as Dina said, really analyzing the data and seeing what we can learn from it and sharing that. So, Huntington's disease does remain one of the therapeutic areas that we're interested in, along with other neurodegenerative diseases. But we don't have anything that is, ready to go into clinical trials anytime soon. It's back to our scientists, and it is a long road ahead from discovery to being able to go into the clinical trial. So we are interested in Huntington's disease, but we do not have anything that will be in clinical trials anytime soon.
Thank you.
After how many doses did you see the peripheral neuropathy? Because you said in the healthy volunteers, it was only one dose that you administered. So in the actual study, the HD study, which timeline was this seen at?
Harry, why don't you
I
take
could,
that?
yeah, it seemed that we were seeing changes around week 9, particularly when it came to the NFL. As I mentioned, we were studying that and are checking it every 4 weeks, every month. So it looked like around week 9, we were definitely seeing changes with elevation, followed by some other changes, either with symptoms or the neurological examination, such as the reflexes. So seems that week 9 sort of started where we were seeing most of these findings, although
And so
it's
since
variable.
it's a weekly dose, so that means that people received 9 weekly doses before whereas the phase 1, they received a single dose. And I think we followed them for 15 days or something. But this would have been after the 9th weekly dose.
And the 2 patients who are participants, I know some people don't like the word patients, the 2 participants who did have clinical neuropathy, those were 2 that were on the active drug. They were not on the placebo.
Yeah, none of the placebo participants had neuropathy.
Okay.
We have a question from Tina, but this time is written. So does follow-up for those who continue in the study include lumbar puncture? Tina asks.
No lumbar puncture. We're following up with MRI and then the nerve conductions and then NFL, but in the serum. So those are really the follow-ups that we've had.
Yeah, we tried to minimize the as you can imagine, the visits assessments were pretty intense during the study itself, and we met with our steering committee and our data monitoring committee to really exclude everything that wasn't essential, so that when the burden to the patients would be minimum for the remaining visits that they have.
And
if I may add, I mean, from talking to the participants who are still followed, they seem to appreciate that they get the reassurance of being followed and to ideally complete resolution of all issues.
That's great to hear.
Can I ask something?
Sure.
Was there any kind of psychological support or to those participants that?
I believe all the study sites and they had prompt and direct interactions with the participants. Sure enough, they were disappointed, so we tried our best to explain the situation. And luckily for many participants in the trial who got discontinued, for instance, those assigned to placebo, they could move on to other trials going on, and those who received a branaplam at that particular dose understood that it makes sense to wait for a complete resolution of signs and symptoms or have a waiting time. So yes, there was psychological support through the sites, not by, to my awareness, not by a designated psychologist, but by the staff, by the physicians, by the study nurses. Everybody was involved in the study and understood how the participants felt.
And did you have any participants saying, the outcome of HD is far greater than having some of this peripheral neuropathy, So I probably would rather deal with that than deal with everything else that is going to come
Yes.
at you with the disease.
We had these discussions, at least at my site. I think it's a very sensible question, and that comes up. So, and I think the answer to this question depends on two things. It depends on context. Context meaning, are there any alternatives that may be safer but may achieve the same aim, that is lowering the burden of mutant Huntington gene products in the body? And as we are all aware, the answer is yes, there are alternatives. And secondly, it also depends on personal preferences. Yeah? And I think it's very hard to anticipate how you would feel with, let's say, intense numbness or weakness on top of your HD. So the question came, and we discussed it, and I asked people to discuss it with their family members and other people whose opinion they valued, and to learn, if they had the chance to, by talking to people who had been suffering from peripheral neuropathy, axonal polyneuropathy, and to get a better sense of what that implies and what that means. And in the conversations that we had locally at our sites, people came back to us after a few days and said, we informed us more what peripheral neuropathy implies, and we see your point of view, let's put it that way.
Well, I would just like to say thank you to Novartis for all the work that you've done, and also to Bernhard and all of the other principal investigators who've been involved. We're obviously really disappointed, but really appreciate the fact that you've taken this time to, to come back afterwards and really explain in so much detail about what has happened and why you've made this decision, and to give us the context. I think that's really important for all of us. So I really appreciate that.
Great. And thanks for giving us the opportunity to do that. We very much appreciate that.
Yes, thank you.